Professor Rono Jose in this Novartis Symposium. Professor Jose is the head of the Lung Disease Department of Center Hospitali Intercommunate Kritai. The talk of Professor Jose, Holistic Approach in Asthma Management. Welcome, Professor Jose.
Thank you for your welcome. I hope you hear me. Normally my presentation is registered. So, well, it's okay.
Good afternoon. My name is Bruno Housset. I would like to thank the organizer for inviting me to give this talk on an overview and bronchial asthma. Slide shows you my links of interest. And I would like to begin with asthma definition. And we are lung physicians, so it's really to be quick. Sometimes it's obvious, the diagnosis is obvious, but sometimes it's more difficult because the physiologic definition of asthma is relatively non-specific. So you need to use the clinical history, but also to use lung function with researching airway hyperreactivity and mainly the reversibility with bronchodilator tests. So sometimes it's so easy, and you have to discuss the differential diagnosis. And here are regrouped the various differential diagnoses depending on the symptoms. On the point of view wheezing, sometimes it's quite difficult to make the diagnosis of vocal cord dysfunction syndrome, and I would like to approach the hyperventilation syndrome, and it is quite frequent. Hyperventilation syndrome is found in the 30 to 40% of severe asthma. So it's important to look for this. It's a differential diagnosis, but also it's a diagnostic that can be associated with asthma. A vocal monophonic wheeze may be the symptom of an obstruction of bronchi by bronchogenic carcinoma or a foreign body. It should not be confused with asthma. Cough, the main causes of cough, of chronic cough, is of course asthma, but also gastroesophageal reflux and rhinosinusitis with the post-drip syndrome. So it is something that should be looked for. It could be also associated with asthma. You know, equally the post-viral tussive syndrome, eosinophilic bronchitis, cough induced by angiotensin-converting enzyme. So this is something that you are used to look for, and the chronic bronchitis with or without obstruction can be also a cause of cough and could react to the treatments of asthma. In front of the dyspnea, of course, you will look for a COPD, but also for a heart failure, and pulmonary embolism is also something that could be frequent. Obesity can also cause dyspnea and is a particular phenotype of asthma. So this step is quite important to look for other diagnostic which can explain some symptoms, or another diagnostic that could be associated with asthma. The following point is to look for comorbidities and to treat the comorbidities. These comorbidities can be linked to a Th2 phenotype like chronic rhinitis or chronic sinusitis, but also atopic dermatitis. And we'll have also to look for gastroesophageal reflux. That can be a cause of cough, but it's also a comorbidity. And obstructive sleep apnea or hormonal disorders, depression and anxiety disorders. And we should look also for some elements that can influence comorbidities or symptoms of asthma, such as history of smoking or exposure to secondhand smoke, hormonal influences, obesity, infections by viruses or bacteria, and finally, occupational exposures. And this is a very important point to look for the occupational exposure that could be associated with asthma. It could induce an aggravated asthma, aggravated by occupation, but it can also be the source of occupational asthma. So this is something important to explore. Searching for comorbidities is important because they can be predictors of asthma exacerbations. You can see here that the type 2 related comorbidities, particularly the nasal polyps, the blue columns here, can be associated with an increase in the risk of exacerbation. Here is the odd ratio for the exacerbation. So that is the case also for sinusitis that is associated with an increased rate of exacerbation here. So it is important not only to look for comorbidities, but to treat them before looking. After the diagnostic step, looking for alternative diagnosis, looking for treating comorbidities, it is important to try to phenotype the asthma and mainly to search for a Th2 phenotype, because it is the phenotype against which we have new therapeutics, and we will see that afterwards. It's quite easy because with a clinical history, you can look for atopy. The skin tests for allergy should be performed. Looking for eosinophils in blood is quite easy. Maybe it's a little more difficult in sputum. Looking for IgE, total IgE or specific IgE, for exhaled fraction of nitric oxide, FeNO, that is a biomarker of eosinophilic inflammation in the bronchi. And here with a question mark, is it necessary to perform a CT scan? And this is still debated. But it's very important to look for this kind of phenotype. Here are the phenotypes proposed by Sallywell in 2012, and depending on the age at onset, you can have here the Th2 phenotypes with allergic asthma, exercise-induced asthma, and later onset eosinophilic asthma. And we have new treatments for this kind of phenotypes. Here we have late onset asthma, mainly in women, with neutrophilic asthma or obesity-associated asthma, also with some modification in smooth muscle. And this non-Th2 asthma is still lacking specific treatment. But it's coming, maybe it's coming. And so once this phenotyping is done, you can classify asthma depending on the silent symptoms and the frequency of the silent symptoms, and in mild, intermittent, or persistent, mild, moderate, or severe. The goals of treatment are first to optimize the control of asthma symptoms. And the specific goals is to make the patient free from frequent symptoms of asthma, to get fewer nighttime awakenings, minimal need for rescue medication, and the best lung function, and to maintain normal daily activities, and to be satisfied with asthma care. So this is the objective. And you can assess the control of asthma using various scores. And the most known are the asthma control test or the asthma clinical questionnaire 5, that are scores that can quantify the control of asthma and is useful for the following of patients, follow-up of patients, and for the assessing the effect of treatment. The other goal of treatment is to reduce future risk of recurrent exacerbations, to prevent this exacerbation and the need for emergency care, to prevent also the reduced lung growth in children and loss of lung function in adults, and finally to optimize the treatment, the medications with less side effects as possible. So these are the goals of treatment. And now we retrieved the classical scheme of GINA. Here is for adults and adolescents more than 12 years old. And at the upper part of the slide, you have this cyclic management of asthma with assessment, adjustment, and review. First, to assess, we have already seen the steps. Then you have to adjust treatments, non-pharmacological strategies, as well as pharmacological strategies, and education and skills training are very important. And then you assess, the review, the response to this adjustment on symptoms, exacerbations, side effects of treatment, lung function, and patient satisfaction. On the lower part of this slide, you have the medication options with these 5 steps with more and more therapeutical pressure. And the new proposal of GINA in the 2020 GINA recommendation is to use here as a preferred reliever the as-needed low-dose ICS formoterol. Formoterol because it's a very quick action comparable to the short-acting beta-2 agonists. And for the step 3 to step 5 is to use low-dose ICS formoterol as maintenance therapy and reliever therapy. So this is quite new. There is some discussion about that. If you are not using formoterol, so another association of ICS and long-acting beta-2 agonists, you should need as-needed short-acting beta-2 agonist as a reliever. This is something that is new, as you can see here, and there is some 2 randomized controlled trials support this proposal of an as-needed low-dose budesonide formoterol strategy in mild asthma. And there is clearly a reduction in severe exacerbations with this strategy versus short-acting beta agonist alone or versus maintenance ICS. And there is no clear difference in symptom controls and the average ICS dose. And now there is near 10,000 patients that have been treated by this regimen. The FeNO was significantly reduced by this as-needed ICS formoterol strategy. But when you look at baseline characteristics, including blood eosinophils and FeNO, they are not predictive of reduction in risk of severe exacerbations. New randomized controlled trials are also being published in African Americans, children. This study shows that the as-needed treatment by ICS is equivalent to the guidelines treatment protocol. And here is the proposal for the children from 6 to 11 years, and you can see that there is less proposal for treatment, and the reliever, the proposed reliever is short-acting beta-2 agonists because of the side effects of corticosteroids in children. the question is to know where to start. When you have a patient face in front of you, how do you start the treatment? And there is two figures that have been proposed by Gina, and I choose one. This one, first it is called blue column. You have to first assess the diagnosis, the differential diagnosis, the triggers, the comorbidities, the inhaler technique and adherence is very important, and patient preferences and goal. So you retrieve here the assessment, and here if there is many symptoms most days, and waking at night more than once a week, and a low lung function, then you can use medium dose of ICS. You start with the medium dose ICS LABA. And if there is symptoms most days or waking at night more than once a week, then a low dose ICS LABA. If there is symptoms twice a month or more, then you can use a daily low dose of ICS or as needed low dose ICS formoterol. And finally, for an intermittent asthma, you can use as needed low dose ICS formoterol. So this is a way to initiate the treatment in adults and adolescents, with a diagnosis of asthma. What is the maximum daily dose of this strategy of as needed ICS formoterol? And here for low dose budesonide formoterol, the maximum recommended total dose in 1 day is 12 inhalations of budesonide formoterol, 200 micrograms, 206 micrograms. And for low dose beclomethasone formoterol, the maximum inhalations per day is proposed to be only 6. So this gives you a practical indication of the maximum daily dose of this strategy. The assessment of symptom control, I have already discussed the ICT and ICQ. Here is the GINA assessment of asthma control in adults, and it is equivalent to the ACT. And the point is that usually you are using the SABA for symptoms as a reliever, as a criteria of no control. But in the GINA recommendations, it is suggested that ICS formoterol use should not be included in symptom control assessments. And there is not many data available, but maybe this is going to be more clear next year. Now, when we are talking about low, medium, and high doses of ICS, what are we talking about? And here these are also proposals of GINA. It is not a table of equivalence, but it gives you an idea of what is called low, medium, and high doses. And it could depend, of course, of country-specific local availability, regulatory labeling, and clinical guidelines. So it's difficult to give a strict proposal on that. But the important point is that low dose of ICS provide most of the clinical benefit of ICS for most patients with asthma. So usually you don't need medium or high doses, but there is some variations between patients, and you can need moderate. And I mean, rarely, it's needed in very, very few patients, high doses of ICS in combination with LABA and normally. So we know that high doses of inhaled corticosteroids are associated with an increased risk of local and even systemic side effects. So it should be discussed, and the balance benefits risk should be assessed. Here, as the tables are going very fast on that, you have the various for adults and adolescents, the various corticosteroids, inhaled corticosteroids available on the market with low, medium, and high doses. And this is for adults. Here is for children between 6 and 11 years, and here for children 5 years and less and younger. You have here the various available corticosteroids. A word about the Association of Asthma and COPD, and this is called sometimes the Asthma COPD Overlap. And it's very important to separate asthma from COPD because the treatment is quite different. In asthma, you need to use corticosteroids, but you do not give bronchodilators without corticosteroids. On the other side, for the COPD, on the right extreme here, you should use bronchodilators and to avoid, if possible, high doses of inhaled corticosteroids. So it's quite different. In the middle, you have this overlap syndrome. That syndrome is now not used, but this overlap between asthma and COPD. And if you are thinking of a sign of asthma, if you are thinking of asthma, you should use inhaled corticosteroids and not give bronchodilators alone. So it's important to separate asthma and COPD, and if you think asthma, you put steroids. Just a warning about Montelukast. It has been a warning from the FDA about the risk of neuropsychiatric events, including suicidality. So it should be, you should consider the balance benefit risks, and the patient should be advised about the risk of neuropsychiatric events. Now I would like to insist on severe asthma. Severe asthma, there is many definitions, but you see here the definition of the task force of ERS-ETS, and when the diagnosis of asthma is confirmed and comorbidities is addressed, and this could take time, as I showed you before, severe asthma is defined as asthma that requires treatment with high-dose inhaled corticosteroids plus a second controller and/or systemic corticosteroids to prevent it from becoming uncontrolled, or which remains uncontrolled despite this therapy. So this is a definition. But the point I would like to insist on is the importance of annual oral steroid dose. You have to calculate to sum the number of short courses of steroids the patient have received, and a yearly cumulative oral corticosteroid dose above 1 gram should be considered unacceptable. And this is a severe asthma, and you should make the case for referral and to discuss the use of biotherapies after eliminating all other causes of ineffective treatment of ineffective inhaled corticosteroids. Even half a gram a year is not normal. It should alert you, and you should look for this, for other causes of difficult to treat asthma. Here are the complications of corticosteroids, of systemic corticosteroids, treatment for more than 6 months, and with low doses of systemic corticosteroids, medium doses, or high doses. And you can see that the risk of complications is frequently occurring even for low doses of corticosteroids. On the other hand, it has also been demonstrated that the use of corticosteroids is associated with an increased mortality in asthma, and the use of corticosteroids is also associated with a higher decrease in lung function. So it is really a harmful treatment that should be, as possible, avoided. And this could be done with new treatments. And these new treatments are biotherapies. And there is 3 classes of molecules available. The oldest one is the anti-IgE, omalizumab, which is available since a few years now. And more recently, there is the anti-IL-5 or anti-IL-5 receptor therapies, and more recently, the anti-IL-4 receptor that is acting on IL-13 and IL-4. I will briefly review the trials showing the sparing effect or the effect of these biotherapies in severe asthma. And the first one is about omalizumab or anti-IgE. This is known for years, and there is many publications about this treatment, and I choose an Egyptian a study performed in Egypt on the omalizumab, respecting the indications of this treatment. You can see here that there is a clear, significant, important decrease in oral corticosteroids from baseline to the month 4. And there is clearly a decrease in the amount of corticosteroid intake, and tolerability is very good. As you can see, the poor tolerability is the small purple line at the top of these columns, and the other one is good, very good, and excellent. And this is quite the same for effectiveness as assessed by physician or patients. And there is patients here that are less satisfied by the effect of treatment, but clearly it's an effective treatment, mainly in patients with an allergic phenotype with the IgE, an increase in IgE. The other molecules, first for the anti-IL-5, and the first one to be published was the publication in the New England in 2014, the Nepalisimab. There is 2 doses but various routes, either intravenous or subcutaneous injection of Nepalisimab at 2 different doses. You can see here on the exacerbation that compared to the placebo, the black line, there is a 50% reduction in the exacerbations, whatever the dose and the route used. And so there is a clear-cut effect of this treatment with a clear-cut, and this is not shown on this slide, but the clear-cut reduction in the oral corticosteroids. There is also an increase in FEV1 using this treatment. Another anti-IL-5 available now is the Restless, and you can see here the effect on the exacerbation, that is the rate of exacerbation in patients with oral corticosteroid at baseline, and the treatment is clearly reducing the frequency of exacerbation in these patients. This is true also for exacerbations needing steroids or needing hospitalization here, mainly in patients with corticosteroid at baseline. And there was also in this paper in a reduction in the intake of oral corticosteroids. Anti-IL-5 receptor. Here you have this study with the 2 arms that are equivalent in efficiency, but here there is a decrease in the dose that is given compared to a placebo. And here at the upper panel, you have a decrease in the corticosteroid intake using the bevacizumab as compared to placebo in the black line. And there's also around a 50% decrease in the rate of exacerbations using this treatment in this lower panel. Finally, the dupilumab, which is the anti-IL-4 receptor antibody. You can see on the upper panel on the left, on the right, that the treatment reduces in a significant way the dose of oral glucocorticoid taken by the patients. It is striking also to see this decrease in the placebo group of the intake of glucocorticosteroids. These are given subcutaneously every 2 weeks. And on the lower panel, you see the increases in the FEV1. And this is a long-term effect of these antibody treatments. So it's clearly a revolution in the treatment of severe asthma. And there are some recommendations of the Joint European Respiratory Society and American Thoracic Society Asthma Task Force, and they suggest for the anti-IgE treatment to use a cutoff for blood eosinophils of more than 260 and a FeNO cutoff of 19.5. You can imagine that between 19 and 20, there is not a big difference. So it's something that is indicative, and then you have to weigh the benefit from the anti-IgE treatment. Then for the anti-ER5 strategy, they suggest to use this in severe uncontrolled asthma with an eosinophilic phenotype, and for those with a severe corticosteroid-dependent asthma, and with a threshold of 150 eosinophils per milliliter, per microliter. This is also to be discussed, depending if you have 200 or 100. There's not a big difference. And we know also that there is some patients that are not allergic and who can benefit from this treatment. And this is also the case with dupilumab, which is proposed in patients with severe eosinophilic asthma, and for those with severe corticosteroid-dependent asthma, regardless of eosinophil levels. So there is no proposal of cutoff. It has been shown in the study published in the Lancet that whatever the eosinophil level, there is the same efficacy of this treatment, which is also indicated in nasal polyps and atopic dermatitis. This task force also gives some advice concerning the addition of tiotropium in patients with GINA step 4-5, and there is some papers recently published on the triple therapy used in severe asthma, which can decrease in some patients the frequency of exacerbations. But it's not the spectacular effect of the biotherapies. Regarding the macrolide treatments, they suggest to try this treatment in adult asthma with persistent symptoms. However, it is known that this long-term treatment with macrolide is associated with changes in the microbiome and also with the apparition of resistance to antibiotics, of course to macrolide, but also to other antibiotics. So it should be used with caution. And it is also proposed not to use this kind of treatment in children and adolescents. The non-pharmacologic treatment is very important. It's in my last slides, but it's important. It's a very key component of treatment. And it is important to engage the patients in becoming active partners in the asthma management. And there is a few points that should be developed with the patient. What is asthma? What are the symptoms? What are the asthma triggers? It is really key for an individual patient to avoid the triggers of asthma exacerbations, and which medication should be used for a quick relief or to control asthma, what is the correct technique for each inhaler for that the patient uses, and just a point, there is a French website with various videos showing how to use the various devices that are available. So it is very useful for patients to look at these videos to use correctly their device. And finally, what are the barriers that prevent the patient from taking medications? And that is something that should be very important to identify: cognitive barriers, socioeconomic barriers, or problems with skills to use the device. Here is the last point. It is the asthma action plan. It is very important to give to the patients the indications for behavior in case of apparition or aggravation of symptoms, to avoid emergency consultations or to emergency or hospitalization for asthma. So this is shown to be efficient to prevent this kind of complication. And the three last slides are about COVID-19. There is some recommendations in GINA about the fact that patients using steroids, inhaled or even oral corticosteroids, should continue taking their prescribed treatments, and they should have also they should continue their biotherapies and do not stop all corticosteroids. So they should have a written asthma action plan with various instructions, and they should avoid nebulizers where possible, because nebulizers are a good way of disseminating viruses and COVID-19, SARS-CoV-2, to other patients and to healthcare professionals. So we should prefer the use of pressurized metered dose inhaler with spacers. The other point is to also avoid spirometry in patients with confirmed or suspected COVID-19, because spirometry is also a way to disseminate viral particles, and it is rarely an emergency to perform a spirometry, so it should be avoided. And it insists, this recommendation insists on the strict to apply strict infection control procedures if there is some aerosol generating procedures used. Anyway, in any circumstances, you should be very strict in the infection control. And there is some recommendation from the WHO on this topic. You have the link here. And the final slide is about some links, also resources for COVID-19 for health professionals or for patients. Thank you for attention, and I'm ready to answer your questions.
Thank you very much, Professor Hossein, for your acceptance to be with us and for this comprehensive and elegant presentation. I have a question about the prevalence of different asthma phenotypes. We know now that chronic type 2 asthma in the few last years we are caring about such patients, and we are now more caring about them because we have many biological therapies which may benefit from it. But about the prevalence in your practice or in your country, what is the prevalence of different asthma phenotypes, especially this type 2 asthma? Thank you.
First, thank you for your invitation again. About your question, these biological therapies are mainly reserved to severe asthma, and severe asthma is around 5% of all asthmatics. So it's really it's not rare, but it's not very frequent. And then you have to look for these type 2 phenotypes, and it is not so frequent, but we know also that some people react to these biological therapies without a clear type 2 phenotypes. But we know now, but there is other cells that can secrete, can release IL-5, for example. And there is some new some ongoing research on this kind of, we know that some patients with no allergic phenotype can benefit of this treatment, but this is clearly only in severe asthmatics. And I would like to insist on the fact that severe asthma is also characterized by the use of oral corticosteroids, and the criteria quite easy to measure is the sum of corticoids, oral corticoids in a year. And really, when you are at 0.5 gram, you should be alerted and look for a problem, either a difficult to treat asthma or a severe asthma that could justify the use of a new biological therapy.
Thank you so much, Professor Jose, for your excellent expose. I have a question. If you have patient with severe asthma and by investigation, FeNO is high, eosinophils high, IgE is high, what kind of biological therapy would you choose in these patients?
I think that the one that we knew for now it's more than, it's 11 years, I think, for the omalizumab to be at disposition. So I think I would begin with omalizumab because it is now a well-known molecule and the side effects are known and there are very few. So I think it should be, and then you have to reassess the patient 4 months later to be sure that it is responsive to this treatment. And if it is not, you can change the molecule, the biological treatment.
Another question, Professor Jose, how long would you prescribe the omalizumab for your patient? Because in Egypt, we are facing a problem. The majority of our patients, they pay for the medication out of pocket. So if you're going to prescribe a biological like the Xolair or omalizumab, how long do you give it to him? I mean, if he's controlled, are you going to stop or you continue the medication?
It's a difficult question because we know that we don't know, in fact, when to stop the treatment. And there is some trial with the stop of omalizumab, but 1 year after 1 year of treatment. And some patients, it's okay. For some others, you have to pursue the treatment. So it's really an individual assessment of the effect. But you can try to stop the treatment after 1 year. But some are treated for many years now.
Yeah. Thank you, Professor Bruno, and for your very elegant presentation. We hope by next year they won't be this COVID.
It would be a pleasure to meet you in person. Yeah, sure.
That would be a real pleasure, and we hope to see you either in Paris or in Egypt. You decide, and you'll be our guest of honor. Thank you.
Great pleasure.
It's a pleasure having you. Thank you very much. Bye-bye.